Thank you so much for coming this morning. So last time we had left off with blood, and we were kind of like halfway through, and then we started doing practice questions. So I'm thinking this morning we're going to kind of do the same thing. I want to finish up blood, and then after we finish up blood, we will pause, do practice questions. I wrote some more this morning, and then we'll come back and do respiratory, because I believe respiratory you guys should have started on this week. So we'll start respiratory, probably do like an outline and talk through it some. So let me kind of do a quick outline for blood, and then we'll talk more about like the details of it. So last week we talked about blood. So remember that when we're doing vascular, because it's cardiovascular, so the vascular is the blood vessels themselves and like their anatomy. And then we talk about the blood and its anatomy. So what's the blood vessel? And then what's the blood? And before we already talked about cardio, which was the heart, right? How it pumped and everything. So for blood vessels, we talked about the fact that we have 3 layers, right? If it's a vein, a venule, an artery, or an arterial. So that was arteries, arterioles, and veins and venules. And we kind of talked about those layers. So if we drew that on our little outline, we would say tunica externa, right? Tunica media, and then tunica interna. And then what was the tunica externa? What was that one made of? Tunica externa. Remember, that was the outermost layer that was made of dense, elastic connective tissue. Tunica media was made of smooth muscle. And then tunica interna was made of simple squamous, right? So those were our 3 layers of a blood vessel. And then we talked about how when we're looking at just capillaries, and remember, this would be both arterial capillaries and venous capillaries. If we're talking about just our capillaries, those have just the tunica interna only. So we'll put number 3 only. And that's because tunica interna is the only one that allows for diffusion, right? And then we talked about the fact that capillaries have 3 kinds and 2 groups, right? So if we do 2 groups, kind of looks like this. 2 groups, we had continuous, which is the one that has no gaps, and then discontinuous, right? Continuous, having no gaps, had just one subtype, which was continuous, right? And this is the one that allows for diffusion. And then discontinuous had 2 types, which was fenestrated and sinusoid, right? So where did we say we found fenestrated with the small gaps? Where did we find fenestrated? Kidneys is the main place, right? Kidneys is the main place. And then it's also found in endocrine glands and the pancreas and the intestine. So you want to know all those locations for your test. And then sinusoid would be your large gaps. Primary place there would be the spleen and the lymph nodes, but it's also found in the bone marrow and the adrenal gland. Okay, again, you want to make sure you know all of your locations there for those different types. And then we said when a continuous capillary converts itself to a fenestrated capillary, what was that process called? Diapedesis, right? And this happens because of basophils releasing histamine, and that causes the conversion of a continuous capillary to a fenestrated capillary, right? And that allows white blood cells to leave. And then kind of a few terms that I didn't really talk about completely were angiogenesis, vasovasorum, and anastomosis. So I'm going to kind of put those on here as bonus things. So angiogenesis, this is the creation of new blood vessels, creation of new blood vessels. So this happens in the case of an injury. So maybe you injure yourself and now you form new blood vessels. anastomosis is the fact that there is multiple blood vessels supplying the same area. So for example, same area. As you age, you perform more and more anastomosis. So a person who has a heart attack when they're 60 years old has multiple blood vessels supplying their heart. And so they basically have other backup options to keep blood flow. So this is why people who have a heart attack at 60, many times they live through it. If most of us here had a heart attack, right, being much younger than 60, we don't have multiple blood vessels. We don't have a lot of anastomosis. And so we're very likely to die because we don't have a lot of blood supply to that area. It's just one option versus all these other options as we perform as we age. So that's anastomosis. For vasa vasorum, vasa vasorum is the specific capillary bed that actually gives blood supply to major arteries and veins. So this is capillary bed supplying blood to major arteries and veins. And this is because they have the 3 layers. So when you have the 3 layers, you can't perform diffusion very well, right? So that the 2 outside portions of it, the tunica externa and tunica media, those need their own nutrients. And so that's why we have the vasa vasorum, okay? We also briefly talked about some valves, and I think you guys all kind of get that, right? We talked about valves on the venous side and how they function to help get blood back to the heart. And remember that varicose veins would be when blood pools around those valves. And if those varicose veins are found around the anus, that would be hemorrhoids, okay? So varicose veins and hemorrhoids. And then we talked about the various functions of blood, right? So we led with some functions of blood, which was like protection, transport, regulation, and storage. Then we talked about how blood is made or created, right? Which is hemopoiesis. And then remember, there are 2 subtypes under hemopoiesis, right? There's leukopoiesis and erythropoiesis. Hemopoiesis is all blood versus leukopoiesis would just be white blood cells. Erythropoiesis just be red blood cells. The functions, again, like I said, kind of go over those. Those are like transport, regulation, protection. And then we talked about the composition of blood. So how is blood, what is it composed of? And we said that the main 2, right, are formed elements and then plasma. And if we look at formed elements, that would be our white blood cells, our platelets, which are thrombocytes, and then our red blood cells or our erythrocytes. Red blood cells is hematocrit. White blood cells and platelets is buffy coat, right? And then overall, formed elements was 45% of the blood, plasma 55% of the blood, and then plasma, 92% is water, 7% is protein, and then 1% is other substances. And then our protein subdivided into albumin, the most common, globulin, the second most common, prothrombin, and fibrinogen. And those prothrombin and fibrinogen are our clotting factors. And if we take plasma and we subtract the clotting factors, we get serum, okay? So that's your outline of what we went over so far in the blood. Hopefully it helps you to see it all in one place. I'm a very visual learner, so outlines always help me a lot. Okay, so the next thing we're gonna talk about with blood is clotting. Okay, so like this, we'll erase that little guy. So if we went over and we draw one more, we're going to talk about clotting. So how does clotting occur in the blood? And then we'll also talk about the oxygen carrying capacity of blood on hemoglobin. So we'll spend a little while talking about hemoglobin and then also how blood is broken down. So we're going to put phagocytosis and we'll talk about that and the byproducts of blood. And then we'll finally end by talking about white blood cells and blood types. So we'll put that here, blood types. So this is kind of what we're going over now. Okay, everything else on the board I went over last SI session. Okay, so we talk about, again, now we're on to blood clotting. So when you look at blood clotting, this is called the formation of a thrombosis. A thrombosis is just a blood clot. So the major components of a thrombosis or a blood clot are going to be fibrin and platelets. So there's a few ways you can kind of think of this. We can do it like this. So fibrin and platelets equal a blood clot. So that's kind of one way to say it. But we have a lot of steps we have to get to form fibrin. So in order to form fibrin, we're going to back it up to the beginning. So first, the very first step we do is we release factor X from damaged cells. So let's say you are in the kitchen and you accidentally cut your finger with a knife. Those damaged cells that just got cut are going to release factor X. This is an enzyme that begins the clotting process. Once factor X gets into the blood, it's going to combine with prothrombin. And if you remember, prothrombin is a clotting factor. It's one of those proteins in the blood. So it's a protein, one of the 7% protein, and it's already in the blood. So once factor X combines with prothrombin, the result is a substance called thrombin. So thrombin, we could say, is number 3, the third thing that happens. Okay, so thrombin would be the result of those two combining, and this is just activated prothrombin. So factor X activates prothrombin to become thrombin. Once thrombin is in the blood, it will combine with the fibrinogen. Okay, and fibrinogen was another one of those clotting factors. So this is a clotting factor. It's one of the proteins already in the blood, just like the fibrinogen. All right, so once the thrombin and fibrinogen combine, we're going to get fibrin. Okay, fibrin will combine with the thrombocytes or platelets that are already in the blood, plus thrombocytes or platelets already in the blood, and together they will form a blood clot. Okay, so the way I wrote this when I was in the class was factor X plus prothrombin equals thrombin. Thrombin plus fibrinogen equals, where's my red? Fibrin. And then fibrin plus thrombocytes equals thrombosis. So whatever way works for you to learn it, you do need to know the order. Factor X is first, combining with prothrombin to make thrombin, to combine with fibrinogen to make fibrin. Whichever way works better for you. If you like this, or you kind of like it written out like I did here, and then going across, either way would work. just know that you do need to have fibrin and you need to have the platelets. Now, the platelets are easy, right? The thrombocytes, these are already in the blood, right? Already in the blood. But the fibrin is the part we have to work on and create through a series of chain reactions. So if you were to create a medication, to stop clotting, right? And we know platelets or thrombocytes are already in the blood. So, you know, that medication maybe would be harder to target those. So if you were to create a medication to stop clotting, what would you target? So what do you think the best place to target clotting would be if you were to create a medication to stop clotting? Which of these would you target? So most medications block something. Okay, thrombin or fibrinogen, good, because that would, the prothrombin or the fibrinogen, you're saying because they're already in the blood. Okay, so which of these is something that if we blocked it, right, if we blocked the action of it, would stop everything else? So what if we stop it? We'll stop everything else from happening. Okay. Let me reword it like this. What is the very first stage? What's the very first thing that happens? Factor X, right? So if you stop factor X, will you get thrombin? No, right? Because it can't combine with prothrombin to activate it. Okay, so now we don't have thrombin. So if you don't have thrombin, will you get fibrin? Fibrin? No. Okay, so if you don't have fibrin, will you get a thrombosis? No. Does everybody see what that means? So prothrombin, fibrinogen, and thrombocytes are already in the blood, but if we stop factor X, we actually stop the whole chain reaction that leads to a clot. So we want to stop clotting in some people, right? Let's say you're having a heart attack or you're having a stroke that comes from a clot. We don't want you to just clot all the time. So this medication is called heparin. And your body actually naturally produces heparin. Your body naturally produces heparin to stop a clot. This could happen maybe if somebody's been clotting for quite a while and your body says, okay, it's time to stop clotting. We're not worried about a bleed risk anymore, because you don't want to just continually clot, right? If you cut your finger, you're not just going to stand in the kitchen clotting for 3 hours. So naturally produces heparin to stop clotting. And this heparin is naturally produced by basophils, which are a white blood cell, right? So basophils release heparin, which naturally stops clotting. By stopping, it stops the release of factor X. Somebody asked about aspirin. So aspirin, technically, if you're wanting the answer to that, you do not need to know this for this class, but aspirin prevents platelet aggregation. So there's a process by which platelets basically aggregate, which is like more complicated than this class, but after fibrin is formed, platelets like aggregate to each other. So aspirin will keep them from aggregating to each other. There are a lot of other antiplatelet medications that act on the factor X process. This is like a lot of them, like heparin, let me think, warfarin and Coumadin, and then Lovenox, I believe, acts on a different part of the clotting factor. But we have I'm telling you, dozens of medications that stop clotting, but the main areas those medications are going to stop clotting is either factor X or platelets. Because if you're going to stop the clotting factors, you're really interested in factor X. Some of them do work on thrombin, but for the purposes of this class, we really want you to know about heparin, because factor X is the most important first step. And I will say that in the hospital, they give heparin quite a bit. So we do inject heparin quite a bit into patients, and sometimes they'll do an IV drip of heparin as well. Okay, so good, I like that. Yeah, heparin, prin, like aspirin. Yeah, I like that. That's good, like thinning the blood. Yeah, heparin thins the blood. Very good, I like that a lot. Okay, so hopefully that kind of made sense to everybody. I'm not trying to confuse you. Just to be very clear, you need to know heparin for your exam, okay? So I was wording it that way, this way, just to kind of make you critically think, but just so we're all on the same page, this is something you need to know for your exam, that heparin is released by basophils, a white blood cell, and that they stop the release of factor X. Good? So the question and the conversation was more critical thinking, but for the test, heparin stops clotting by stopping factor X. All right, so for our red blood cells, remember that we have, they are erythrocytes. I feel like you guys know that now. A few things that you should already know about them at this point, but they are biconcave, so they're a biconcave disc. This is just their shape. This is because they have no nucleus, and so there's the biconcave allows them to fit through capillaries, so through small capillaries. They kind of wedge themselves through, so this is why they actually have a very short lifespan. So they have a short lifespan. I don't think you need to know for your test, but they only live for 30 days because of the fact that they're constantly basically getting damaged through the little capillaries. So the no nucleus would be a disadvantage. The fact that they can fit through the capillaries, that's a big advantage you're supposed to know, right? Allowing them to squeeze through those capillaries. You already know that they are made from a stem cell in myeloid tissue, right? You know they're made in myeloid tissue. Myeloid tissue is also called red bone marrow or spongy bone. And its function, right, was what? Was hematopoiesis, which is the making of all blood, including white blood cells and red blood cells. Okay, so what is the function of the red blood cell? Its function is to carry oxygen. The structure that actually carries the oxygen is the hemoglobin. Okay, hemoglobin carries the oxygen. So if we picture our red blood cell, kind of looks like this. On the surface of the red blood cell are they kind of look like little arms, and they're on both ends, well, they're on every surface. And these little arms attach themselves to little oxygen molecules. So they grab onto oxygen and they transport it. Now, when that hemoglobin gets to the lungs, well, that's actually not true. It's more like this. The lungs give that red blood cell oxygen, right? Because we know the lungs give oxygen. So when the red blood cell arrives in the lungs, it actually is carrying on its little arms, and we'll talk about this in just a second, what this is called, but it actually carries carbon dioxide as well on that hemoglobin. And when we get to the lungs, the carbon dioxide is offloaded and you breathe it out. And then the oxygen trades places with the carbon dioxide. So those little hemoglobin, their main function is to carry oxygen, but they also do carry carbon dioxide for gas exchange, right? So when we actually need to exchange that gas in the lungs, they do also help to carry the carbon dioxide. Okay, so back real quick to our makeup of the red blood cell. What is the red blood cell made of? It is made of a phospholipid bilayer and hemoglobin, right? Phospholipid bilayer and hemoglobin. And that's what I tried to draw here. So this would be my phospholipid bilayer up here. And then I showed you the hemoglobin. Does that make sense? There is no nucleus. And so therefore there are no organelles. There's nothing else in that red blood cell other than a phospholipid bilayer and hemoglobin. Okay, so that's going to be important when we talk about phagocytosis. Okay, so again, going into our hemoglobin. So the hemoglobin is actually, like we said, it carries oxygen. It is a cofactor. I need to just draw this in blue. Give me a second. Hemoglobin is a cofactor between iron. So iron is the heme portion of hemoglobin, and protein, okay? And the protein is globin. Remember how we just learned about globulin in the blood? Globulin, the protein, so there we have it, globin and iron or heme. So this is why blood is red, okay? So if a person has, a patient has anemia, okay, and we're going to talk about this in just a second. Anemia is a loss of basically hemoglobin for some reason or another. So a patient has anemia or a loss of hemoglobin. Will their skin color be extra red or extra pale? Will their skin color be extra red or extra pale if they have a loss of hemoglobin? Pale, right? So if hemoglobin gives our blood its color and we lose that hemoglobin for some reason or another, that patient, one of their symptoms is that they will have pale skin, right? So that's like a really simple way of just saying, showing you how hemoglobin gives our blood its color, gives our skin its red color, the redness that's in our skin. Okay, so like I said, when we come to gas exchange, you breathe in oxygen, and that oxygen comes into the alveoli. It gets transferred into hemoglobin on the red blood cell, like I just showed you. And then it will go back to the heart, to the left atrium, right, to the left ventricle. And then it will go out to the body through the aorta. And then you know that it goes through systemic arteries, systemic arterioles, systemic capillary beds. It gets all the way out to systemic tissues, and that's where we have gas exchange. And that's when the systemic tissues give back carbon dioxide and waste. And the red blood cell does help carry that carbon dioxide, like I showed you. And then it will make its way back to the lungs, right? Going back through veins to the right atrium, to the right ventricle. And where does it go next? To the pulmonary trunk, all the way to the lungs, right? Through pulmonary capillary bed. And that's where the gas exchange occurs. And that is when it goes back into basically the alveoli, but this time it will be breathed out. So that's like a really simple arrow format of showing you where the passage of gas is. So we breathed out the carbon dioxide, and then you'll take another breath in. You'll breathe in oxygen, getting down to your alveoli, onto your hemoglobin, circulating out to the body until the body gives back carbon dioxide and waste here. And then we actually end up breathing out that carbon dioxide at the end. So that's kind of the process of gas exchange, and hemoglobin is the main player in gas exchange. Okay, so when we talk about how the carbon dioxide is carried on the red blood cell and in the blood, we kind of get into some more details here. So I'm going to erase this side so we can keep it on the same page. Leave this. Okay. So how is carbon dioxide, oxygen carried in the blood? So when we have oxygen bound to the hemoglobin, we call that oxyhemoglobin. Oxyhemoglobin is oxygen plus that hemoglobin. So when that hemoglobin is carrying the oxygen. It's called oxyhemoglobin. Now for carbon dioxide gets a little more complicated, and there's a few terms you kind of have to know about this. So 70% of carbon dioxide is not carried on the red blood cell, okay? 20% of carbon dioxide is actually carried on hemoglobin, and that's the part I talked about. That's called carbaminohemoglobin. Carbaminohemoglobin. This would all be one word. Carbaminohemoglobin. Good? So that's the name for when carbon dioxide is carried on the hemoglobin 20% of the time. 10% of the time, carbon dioxide is just straight gas. So it's just floating in the blood. But what about the 70% of the time? What about the majority of the time? It is carried as a bicarbonate ion. Bicarbonate ion. So bicarbonate is one of the most important things that you will learn about in anatomy and in physiology, and you'll come back to it when you're in nursing school. So bicarbonate ion, I'm going to write it down here. So its function is to neutralize acid. So it functions as a buffer. So it's called a buffer. So it is keeps blood pH neutral. So your blood can only stay between 7.3 and 7.4. All right, so if your blood becomes less than 7.3 or more than 7.4, your body has a problem, okay? So if your blood is less than 7.3 pH, we have what is called acidosis. And you're going to learn more about this when you get to physiology, and then you're going to learn about it again in nursing school. When you go over 7.4 pH, you have alkalosis. So if you've taken chemistry, this should make sense to you. Alkalosis is a higher pH. This just means it's like, I don't know, it's alkalytic. It's something that makes sense when you take chemistry. Acidosis, it's an acid if it's less than 7.3, okay? So that's something you need to know for your test. Acidosis is less than 7.3, greater than 7.4 is alkalosis. So if we get into acidosis or alkalosis, this means that the bicarbonate ion has failed to act as a buffer. So your bicarbonate ion has failed to buffer the system, and now you've become acidotic or you've become alkalinic, okay? And once you are basically out of pH, once your pH is out of balance, the protein shape in your blood will change. So this is like your enzymes changes. So for example, i.e. enzymes change. Once enzymes change, your metabolic reactions change. Once your metabolic reactions change, everything changes. So for example, Wednesday, I had a patient who had acidosis, and he was really confused. He was mentally very confused because his acidosis was causing his enzymes to change, which was basically making his brain function change. Does that make sense? Your body can only handle being in 7.3 to 7.4. If it's 7.29, it's acidosis. If it's 7.41, it's alkalosis. So you need to be very aware of this very, very narrow range. Technically, it's 7.35 to 7.45, but for this class, it's 7.3 to 7.4. All right, so close enough. Okay, so when we carry that carbon dioxide, as the bicarbonate ion, we call that, see if I can erase this guy. Okay, we call that carbonic acid or carboxylic acid. So that is the name for carbon dioxide carried on the bicarbonate ion. We're calling that carbonic acid or carboxylic acid. And the way that the bicarbonate ion neutralizes acids is it actually attaches to hydrogen ions. And you'll learn that more when you get into physiology. So don't stress too much about it now, as long as you understand what I've said here. So what does the bicarbonate ion do? It acts as a buffer, keeping the pH neutral between 7.3 and 7.4. If we change that, that would be acidosis or alkalosis, when the bicarbonate fails to act as a buffer. When the carbon dioxide attaches itself to bicarbonate ion, we call that carbonic acid or carboxylic acid. These are almost two separate topics in a way. The lower part of the screen here is just talking about bicarbonate, and it's not really talking as much about carbon dioxide for your purposes. When you're talking about carbon dioxide on the bicarbonate ion, we're calling it carbonic acid or carboxylic acid. When carbon dioxide is carried on hemoglobin, we're calling that carbaminohemoglobin. And then you need to know 10% of carbon dioxide is straight gas in the blood. So the lower part of the screen is more about bicarbonate ion, and the upper part is about carbon dioxide, if that makes sense to everybody. So hemoglobin, the majority of the time carries oxygen, but it also can carry carbon dioxide. Remember, oxyhemoglobin is when it's carrying the oxygen. Carbaminohemoglobin would be when it's carrying the carbon dioxide. And then we already talked about bicarbonate ion. Does that make sense to everybody? So we're in the red blood cell, talked about hemoglobin. So now let's talk about how the red blood cell is broken down. Does anybody have questions about this page before we move on? Okay. Just so you know, for your, I don't know, I just feel like, I think it's my OCD. Just so you know, technically these numbers are 7.35 and 7.45. I just think it's better for you to think that somewhere in your brain, because that's like definitely what it's supposed to be, but we just say 7.3 to 7.4, but accurately it's 7.35, 7.45. You don't need to know that for your test. I just really feel like you should know that, because that would be the accurate numbers. Okay, phagocytosis. So this is how red blood cells are broken down. Okay, phagocytosis occurs in the liver, and it occurs by hepatocytes. So by hepatocytes, these would be liver cells. So liver cells break down the red blood cells, and then they are going to create products from them. So it occurs in the liver, and it occurs in the spleen, but only about 10%. 80 to 85% is in the liver. Only 10% is in the spleen and the bone marrow. So where are they created? We remember that they're created in myeloid tissue, but now they're going to be broken down in the spleen and bone marrow. Here is the timeline. I said 1 month, it's 4 months. So they are replaced every 4 months. So that is here in your notes and something you would need to know. So they're replaced every 4 months, done by the liver and by the spleen. So what are the byproducts of red blood cell breakdown? So remember that we said that there are two main structures of a red blood cell, right? What were they? Wasn't it the phospholipids? And I said I'd come back to it. The phospholipids, and then the hemoglobin. And we said, what about the hemoglobin? The heme is iron, the globin is protein, right? Everyone remember that? Okay, so when we take the protein component, which is the globin, and the phospholipids, we create a substance called bile. So again, bile comes from phospholipids and globin. The function of bile is to emulsify fats, turning them into a liquid for digestion. And what we're going to talk about this probably next week. Bile is stored in the gallbladder. So I don't know if you know anybody who's ever had their gallbladder removed, but if you've ever had your gallbladder removed, you can't eat really fatty foods because you don't have a way to digest large amounts of fat. Does this make sense? Bile helps with the digestion of fat, and it's stored in the gallbladder. Okay. Next, we have our bilirubin. So we're going to take that iron and we're going to convert it into bilirubin. So your body is the best recycling system. It takes that red blood cell and it's going to use all of the components of it. So the iron component of the hemoglobin, it's going to use to make bilirubin. Bilirubin is then recycled. So your body breaks it down to then form new red blood cells. Okay, so bilirubin, we don't talk a lot about its functions, but when a person has liver failure, their bilirubin builds up and we see them, they look yellow. And this is because their liver is not functioning correctly to like get rid of it. So bilirubin is again recycled iron. So your body will use it again to make new red blood cells. Okay, so I kind of mentioned anemia, but now we're actually going to say, what do you need to know for anemia for your test? So the definition of anemia is a loss of functional red blood cells. Okay, so the number one way that we can get anemia is by just losing blood. So anemia from the loss of blood would be the first type of anemia. The next type of anemia is a person who doesn't have enough iron. So this is called iron deficiency anemia. You guys have probably heard of this. Most people will be like, oh, I was anemic, so I'm taking iron now, if you have ever heard that. So this is when there's insufficient iron to make hemoglobin, right? Because hemoglobin is made of what? Hemoglobin is made of iron and protein. Iron is the heme, globin is the protein. So if there's insufficient iron to make hemoglobin, now we cannot carry oxygen well, right? Because that hemoglobin is not the right shape. It can't carry that oxygen. Kind of like if we picture our little red blood cell, and remember how I drew the little hemoglobin like this and it attached? Well, now picture that all the hemoglobin looks like is this. It doesn't even have arms anymore. So now it doesn't have the ability to carry oxygen. The third type is going to be our pernicious anemia. I'm going to draw this as pernicious anemia. Pernicious anemia is when there's insufficient globin. So there's insufficient protein or globin, protein / amino acids, because amino acids make up protein to make hemoglobin. So again, the hemoglobin is just hanging out without arms and it cannot carry oxygen. Again, cannot carry oxygen. So like we said, all anemias are going to be the loss of functional red blood cells. The first type, when we just lose blood. The second type, when we don't have enough iron to make hemoglobin. And the third type, when we don't have enough protein to make hemoglobin, called pernicious anemia. And you do need to know, obviously, all three of those for the test. Okay, so what about the reverse? What about if we have excessive an excessive number of red blood cells. So here we have too little, right? Anemia. Well, the reverse, if we have too many red blood cells, we call this polycythemia. Polycythemia is when we have too many red blood cells, and this is excessive number of red blood cells. Polycythemia. It's just something on your test that you need to know. Okay, so let's talk about blood types and white blood cells, and then we'll do some practice questions. So going back really quick over, oops, wrong thing. Going back over here, we did clotting, right? Clotting was this page, blood clotting and that process. Then we talked about hemoglobin just now, right? We talked about O2 and CO2, the acid-base system, kind of all of that. We talked about phagocytosis and how we create bile and bilirubin. And we talked about anemia as well, anemia. Now we're going to talk about blood types. And we're also going to talk about white blood cells. I kind of definitely ran out of room on this outline, but those are our next two topics related to blood. So if I really wanted to, if I was studying this information, because I tell you guys, I really recommend making outlines, I would be doing a whole separate page for a blood outline and a whole separate page for blood vessels. Okay, I was just trying to show you on one page in the beginning, but those kind of need their whole page because there's a lot going on. So we just finished talking about phagocytosis and anemia. So for blood types, so when we talk about blood types, you've probably heard of type O, type A, type B, all of that. So if you have a type A blood, you have the ability to fight off A antigen. So this means you have A antibodies. So antibodies fight off an antigen. Antibodies fight off an antigen. If you have type B, same thing, but for B antigen. You have the ability to fight off B antigen, you have B antibodies. What about if you have type AB? You would have both. You have both antibodies. All right, so if I give you this patient, if I give them A, they can fight it. They fight it. This means that they won't have a reaction, no reaction. If I give them B, they have no reaction. Does that make sense? They can fight both A and B. Okay, what about if we have type O? Type O cannot fight A or B. So if I give this person A, they will have basically an allergic reaction. They could, basically this is an extreme anaphylactic allergic reaction. This can very quickly cause death. We'll say causes death. It doesn't always cause death, but it can cause death if we give them the wrong blood type because they cannot fight A or B. Now there's also something called the Rh factor. The Rh factor means you can fight off the Rh antigen. So what this means is you have Rh antibodies. If you have the Rh factor, you're considered positive. So have the ability to fight, so that have the ability, have the antibodies. If you're negative, you do not have antibodies. Okay, so if I'm A, B positive, I can fight off. This basically means I have the antibodies for A, B, and Rh. What about if I'm O negative? I have no antibodies for A, for B, or Rh. So there's nothing. So the universal recipient is AB positive. Think about it like this. If you're very selfish, right? Very selfish, not very selfish. For your own personal benefit, it would be better to be a universal recipient, because you can if you get injured and you're unconscious and you cannot tell them your blood type, no matter what, nothing will happen to you. Does this make sense? You can't have an allergic reaction to a blood product because you can receive A, you can receive B, and you can receive RH. So no matter what they give you, you will not have a reaction. So universal recipient means there's no possible reaction to blood that's given. Technically, there is a possible reaction, but that's not this class. For your purposes, AB positive, there's no possible reaction. They're a universal recipient. They can fight off anything that comes at them. If you're O negative, this is a universal donor. This is because you can give your blood to anybody and you don't have to worry about a reaction, right? Because you have no like fighting agents in your blood. So if I have A blood, but I don't have B, I can receive O. Does that make sense? Because basically there's no B, there's no A in the O. If I have AB blood, I can receive O. If I have O blood, I can receive O. Does that make sense? If I have O positive blood, I cannot receive A positive, but I could receive O negative, right? Because O negative has nothing. So just know for your test, the O negative is the universal donor because it never has a cross reaction, never has a reaction with someone else's blood because, again, it has no antibodies. It has nothing that could possibly form a reaction with somebody else's blood. Never has it. This is interesting. I wrote the same thing. Never has a reaction with the person it gives to. So this means that never has a reaction with the person it gives to. Unfortunately, a universal donor can only receive O negative. So this means it would be very negative. It wouldn't be good to be a O negative and be unconscious, because if they give you any blood besides O negative, you could die. Does that make sense? Versus a universal recipient has no possible reaction when they're given blood, but they cannot donate to others because they could form a reaction with someone else's. Hopefully that makes more sense. Sorry, I kind of said it weird, but hopefully that's clear. So you want to be AB positive. That's what you really want to be, unless you're wanting to donate, and then you would want to be O negative. Okay? Just think of what you have the ability to fight, and then you'll be able to think about the AB positive and O negative better. So for our white blood cells, we're going to go over these and then we're going to do questions. So for our white blood cells, remember we have our two subdivisions, right? We have our agranular white blood cells and we have our granular white blood cells. And remember, granular end in Phil's, agranular end in site. Remember that we have our mnemonic that we're supposed to do, right? Our mnemonic is never, that's neutrophil, let, lymphocyte, monkeys, monocyte, oops, I need more room, monocyte, eat, eosinophil, bananas, right? Basophil. I'm kind of drawing them over here because I want to put all my granulars together as Phil. And then over here, I have my sites as agranular. But just make sure you remember that mnemonic. Remember that for never let monkeys eat bananas, right? For never let monkeys eat bananas, the mnemonic. This is for commonality. So neutrophil is the most common white blood cell, because it's never let monkeys eat bananas. For bananas, that would be the last. So basophil is the least common. okay? I'm gonna just, I realize that I need to actually just write these all together because I want to do our functions and that will only line up when I put them side by side. So never let monkeys eat bananas. Okay. So for our functions, that's BAMF, right? So this is BAMF, goes like this, B, A, M, P, H. Over here, I'm just gonna write it like this so you see. So if you have your mnemonic, you're gonna write it side by side with this. So that's because neutrophils go with B as the function. So they phagocytize bacteria. Lymphocytes go with A. They have the antigen antibody complex. Monocytes go with M. They become a macrophage. Eosinophils go with P. They phagocytize parasites. Basophils go with H. They release histamine and heparin. Okay, so let's talk about the process of how white blood cells work. So our very first step is we're going to get the release of histamine from the basophil. And what does that cause? Hopefully that's ringing a bell for somebody in here. That causes diapedesis. What did we say diapedesis was? Diapedesis is the movement of a continuous capillary, right, to a fenestrated capillary. So what happens first is diapedesis occurs, that continuous capillary floating with, let's put some little white blood cells in here. Those are my white blood cells. Becomes a fenestrated capillary. So what triggers diapedesis or the release of histamine? The presence of an antigen. So we're going to do the presence of an antigen triggers the release of histamine from the basophil. So we're going to write ourselves a few little antigens. So I'm going to draw a bacteria. I'm going to draw a virus. And then I'm going to draw a little parasite. So bacteria, a virus, and a parasite. So let's say that this person, you know, really drank some water and it was just, or ate some food that was just filled with all kinds of stuff, really gross. So now they have a bacteria, a virus, and a parasite that the basophil saw and realized, okay, well, we need to go out and kill that. We're going to send histamine to cause diapedesis. So now that diapedesis has happened, we get step number 2, which is our lymphocytes. So lymphocytes leave the vessel, leave the blood vessel, and paint or flag the antigens as a bacteria, a virus, or a parasite. So essentially what they do, this is what the antigen antibody complex is. The lymphocytes go in and they install like a little marker. So you could kind of picture it like this. And it's like a little flag that's telling the other white blood cells what's there. So this is a flag called the antigen antibody complex. So these flags are actually antibodies. So if you ever hear of like, you know, antibody therapy for COVID-19, these little flags are antibodies and they are how your immune system recognizes what's present. So that's why if we want, like, you know, when they were giving antibody therapies, I don't know if you heard of that. Anyway, so for COVID, they were giving people antibodies to the COVID virus that were allowing their immune system to see that that virus was present and go and kill it, if that makes sense. So instead of having to naturally let your body do it, they were giving people those antibodies already to help the body see that. but your body forms antibodies naturally through a process that we're seeing right now. First, it's histamine from the basophils, then the lymphocytes form those antibodies. Step number 3 is that now we've actually flagged those different bacteria, virus, parasite, our different white blood cells are going to leave. So the monocytes become macrophages, and they perform generalized phagocytosis. So the macrophages can eat anything. So they're going to go out, and we're going to say that for this one, they eat the virus. So let's draw ourselves a little macrophage. So this is my little macrophage here, and he's eating the COVID virus. Let's say this person got COVID. Okay. All right, step number 4 here is my eosinophils leave. And they are going to eat or phagocytize parasites. So here's my little, what is it, eosinophil? Here's my little eosinophil, and he's working on eating this parasite, okay? And then my last one, number 5, is my neutrophils, right? And my neutrophils eat bacteria. So here's my little neutrophil eating that bacteria. Does that make sense? So the thing that releases the histamine is the basophil causing diapedesis here. And then we have the actual eating of them by the 3 different types. Now, what about, what's the other function of the basophils that we already talked about? I'm going to write it as a bonus. Basophils also release heparin to stop clotting. So basophils have 2 functions. One of them is here in this whole process, helping to basically attack foreign invaders, but the other function is our heparin to stop clotting. Good? Is this making sense to everybody? The process of white blood cell working in the immune system. Okay. All right, any questions at all before we erase our boards and then do some practice? So we went through all of this. All right, I'm gonna stop share in that case and pull up the questions. Okay, so some of these were the ones we did last time. We ended with 9. So let's do question 10. Let me zoom in a little bit. Question 10, the tunica externa. Everybody can see that, okay. The tunica externa is, which of these would be true? So let's all answer this. You can put your answer in the chat. There we go. Good. Okay, so I had some different people answer E, right? So E is correct because the tunica externa is made of dense elastic connective tissue, not dense regular. It does not allow for diffusion because it's a thick outside layer. and it is not found lining any capillaries. It's found on arteries, arterioles, veins, and venules. Venules. Okay, good. So the lymph nodes for question 11, the lymph nodes have which specific type of capillary? Good, so it's sinusoid, right? Remember that's the spleen, the lymph nodes, the adrenal gland, and the bone marrow, right? So that's the location of our sinusoid. Remember, our fenestrated is our kidney, our endocrine glands, and two other places that I'm blanking on. Okay, histamine triggers which of these? So let's answer number 12. Good. Diapedesis, right? We said that vasa vasorum, this is the capillary bed that supplies our triple layered vessels. So like our arteries, arterioles, veins, venules, that's our vasa vasorum. Angiogenesis would be the creation of new blood vessels. And then diaphoresis is sweating. So this is just something you don't cover in this class. So vasa vasorum, angiogenesis, diapedesis, this is the process of converting a fenestrated capillary to a, continuous capillary to a fenestrated capillary. And we know that that is what happens based on histamine, and that's what we just talked about with blood, white blood cells. I didn't talk about this, but I thought that we would just cover it in a question. So what is flutter? And then you can choose from these options here. All right, so less than 60 beats per minute, so these are just a few more heart ones that I didn't talk about, is bradycardia. So if you see bradycardia on your exam, that is less than 60 beats per minute. More than 100 beats per minute is tachycardia, more than 100 beats per minute. More than 200 beats per minute is flutter. No regular heartbeat is fibrillation, and fibrillation is deadly. Okay, so fibrillation is deadly. So our answer to this one would be C, more than 200 beats per minute. But you do need to know for your test all four of these, that brady is less than 60, tachy more than 100, flutter more than 200, and fibrillation with no regular heartbeat, and that it's deadly. All right, so which of these is not a function of blood? Okay, so remember that our blood does help with temperature control through vasoconstriction and vasodilation when you are sweating if it's hot, and then also if it's cold, diverting that blood. We talked about that a little bit. It transports oxygen on hemoglobin. It does function to help with hormonal regulation because hormones always travel in the blood. So that's how the blood functions with hormonal regulation. If you didn't have the blood, hormones could not regulate because there would be no way for them to travel. So because the blood transports hormones, it does help with hormonal regulation. Does that make sense? We know it helps with thrombosis formation, which is blood clotting. We already talked about that today. So hopefully that makes sense for the people that were kind of confused on C. It does help because hormones are always transported in the blood. So which of these is not true of leukocytes? I'm trying to say here, creation. Good. So everybody's saying A. What would the answer be if I change this to hemopoiesis? So let's answer it one more time. E, right? So remember that hemopoiesis is both erythropoiesis, which is red blood cell creation, and leukopoiesis, which we know as white blood cell creation, would be hemopoiesis. So if that's what I have in A, we know that A would actually be true. Does this make sense? Because A consists of both red blood cell and white blood cell creation. We know that leukocytes are created in the bone marrow. We know that they do mature in lymph nodes and that basophils are the least common. So none would be correct. That's what I was trying to go for earlier, but I changed it. And you were right when you guys said A, because obviously erythropoiesis is for red blood cells. Okay, so let's answer this one. Blood, not true. Which of these is not true about blood? All right, so we know nobody's answering A or B, so that's good. So you guys know that it consists of the formed elements, and we know that those are the red blood cells, white blood cells, and platelets. And we know that it consists of plasma, which is the water, proteins, and other substances. So no one's answering A or B, which is great. So blood is actually approximately 1 gallon. This is true. But it is approximately 4 liters, not 5 liters. So the correct answer here is actually D, because blood is 4 liters or 1 gallon. So 4 liters equals 1 gallon. So 4 liters is almost the same as 1 gallon. So the answer here is actually D, because blood is approximately 4, not 5 liters. I'm not 100% sure you would get that exactly like that as a test question, but you may be asked if blood is a gallon or if blood is 4 liters. So I wanted to make sure you guys knew that 4 liters is a gallon. So both of those are true. I have both of those in my notes, so it very well could be on your test, okay? Let's answer 17. So what is these is true about the proteins in blood? I guess I should be writing true. Good. C, right? So they're not used for immune function. That would be white blood cells. They don't make up the formed elements. That would be red blood cells, white blood cells, platelets. They make up the plasma alongside water. And they don't consist of the buffy coat. The buffy coat is our white blood cells and platelets. Good job, everyone. Okay, so the buffy coat is not good. So remember the buffy coat. So it is our white blood cells and platelets. So this leukocytes would be our white blood cells. Thrombocytes are our platelets. So we know it's not B or C, but is it A or D? So the buffy coat, the formed elements, what are formed elements? Formed elements are red blood cells, white blood cells, and platelets. Red blood cells, their other name is hematocrit, and white blood cells and platelets, their other name is buffy coat. So if this is how I write this, doesn't this make sense that formed elements is actually consisting of hematocrit and buffy coat? Or I could say red blood cells, white blood cells, and platelets. Does that make sense? So formed elements is all of the blood, whatever the blood cells, whatever I want to call the blood cells, that's the formed elements, whether I call them hematocrit and buffy coat, or I call them red blood cells, white blood cells, and platelets, that's formed elements. Erythrocytes or red blood cells are not part of the buffy coat. Erythrocytes or red blood cells are hematocrit, so not buffy coat. Does that make sense? So the correct answer is D, because the buffy coat is not made of erythrocytes. Hopefully that makes sense. Oh, so, okay, so for question 19, which of these is the first key step in clot formation? All right, so several of you are saying E, none, which is correct, and hopefully you're remembering that from the little question we went through. So the correct answer is factor X, right? Because we said that factor X is the first step. If we stop factor X, we stop everything else. So factor X would be our first step. Heparin functions, which of these is true about heparin? Good. So we all kind of went over that together, right? Someone said heparin thins the blood. I think that that's really helpful. Just think heparin doesn't stops clots. So inhibits the release of factor XD would be correct. All right, so let's talk about question 21. Hemoglobin, which of these is not true about hemoglobin? Good. So you guys all got that. It does not carry bicarbonate, right? Bicarbonate ion is a separate substance in the blood. It is not part of hemoglobin at all. Very good. Nicely done, guys. Erythrocytes, which of these is not true about erythrocytes? Good. I have you guys about 50-50. So we know that byproduct does become bile, and we noted that a byproduct does become bilirubin of red blood cells. We know that 10% are phagocytized in the spleen, right? And 80 to 85% are 80 to 85% are phagocytized where? In the liver. Remember that the liver, we can also say that that abbreviation is hepat. So like you guys are supposed to know hepatic arteries. What is a hepatic artery? A hepatic artery supplies the liver with blood. So if you see hepatocytes, that means liver cells. So phagocytized by hepatocytes just means in the liver by liver cells. Does that make sense to everyone? So that would be true. D would be true. So E is the correct answer because actually all answers are true. Is that making sense to everybody? Some people put D, so hopefully that makes sense why that one's true. So why we have to choose none, because all of those answers would be true. Pernicious anemia involves which of these? Okay, so I have a little bit of a tie here on answers. So we know that insufficient iron on the red blood cells would be iron deficiency anemia, right? So that's not A. Insufficient quantity of red blood cells would be blood loss anemia, which is not pernicious anemia. Insufficient globin on the red blood cells is the definition of pernicious anemia. Remember, pernicious anemia would be insufficient globin to make hemoglobin. So we reduce the amount of hemoglobin and it reduces the carrying capacity for oxygen. Insufficient carbon dioxide on red blood cells is not a condition. So I had people saying C and I had people saying E. I'm not sure the confusion there, maybe just not seeing globin, but this is the correct definition of pernicious anemia. Insufficient globin on the red blood cells to make hemoglobin, okay? So I didn't need to write out to make hemoglobin, you know, it's insufficient globin would be correct. Another way you could actually see this on the test is insufficient amino acids would also be correct, okay? So just know that insufficient globin or insufficient amino acids, both of those would be correct definitions of pernicious anemia. If you don't have enough hemoglobin, you can't carry carbon dioxide. Yes and no. Remember that 70% of carbon dioxide is actually carried on as bicarbonate ion. So you're not really worried about the 20%. Does that make sense? So yes, the hemoglobin does carry carbon dioxide. And yes, if you had it damaged, you probably wouldn't carry it as well. But the majority is carried elsewhere. So it's not really where we're concerned about insufficient carbon dioxide on the red blood cells. That's not something we really think about with anemia. Very critical thinking. I can see your logic, but I would just say that would be maybe like overthinking the question a little bit. It's just very simple. What is pernicious anemia? Insufficient globin. The carbon dioxide aspect, like I said, for 20%, we're not really concerned about that. But it's a really good point. Okay, so that's the end of those questions. Would you guys like to, so we have kind of two options here. Would you guys like to go over the respiratory and blood cells models? Or do you want to start respiratory? So models or respiratory. I'm kind of leaning towards doing respiratory Monday of next week. and doing models now, if that works well for everybody. I feel like that kind of makes more sense. Is that good with everybody? Models? Okay, sounds good. So on Monday, we will work on respiratory on Monday. And then Friday of next week, I'm doing Fridays for the month of March. So for the month of March, we're going to Friday SI sessions. So on Friday of next week, I will be doing finishing respiratory, and we'll work on maybe some respiratory models. Trying to look at something real quick. Yeah, because the following week, wait, that's the following week. That's next week. Okay, let me think. March 23rd? Is that right? March 23rd. Wait, do you guys have a spring break? The week in here? Nice. I don't get a spring break. It's very sad. Okay, that'll be good. Well, you guys can take a week off then. Okay, that'll work. So when you guys come back from your spring break, I'll do some review sessions with you guys. Okay, I'm gonna go over larynx, and then I'm gonna go over thorax and blood cells. Yeah, so next week is the week before your spring break. So let's plan to do respiratory and digestive next week. So that means I'll probably have to be a little bit ahead of the information, but I feel like that'll be better because then you guys can review for your test over the break. Does that make sense? So plan to try to stay up on your lectures, maybe even get a little ahead if you can, because I want to do respiratory and digestive next week. Digestive will be Friday, respiratory Monday. And then that way over your break, you can review everything. And so when you guys come back the week before right before your exam, I should be able to have a session and we can do a review session. Hopefully that'll work. Trying to like think of all the dates in my head. Is the 23rd a Monday? Let me see. 23rd, oh, that's the wrong month. 23rd is a Thursday. Okay, yeah, that'll work. So on the Monday, the 20th, we can do a review session before your lecture exam. Hopefully I didn't lose everybody on that. I was, so I'm saying that this coming week, we're gonna do respiratory Monday, probably models too, and models and questions. And then on Friday, we're going to work on digestive and models and questions. And then you guys are gonna have your break. And then Monday, March 20th, I will do a review session I'll probably focus on lecture because I feel like this exam lecture is gonna be where everybody falters. So I'm probably gonna do a lecture review. We'll probably do a lot of practice questions. And then I'll do maybe some outlines of any topics that people were confused about. Good. So coming week, respiratory and digestive, and then you guys will have your break. And then Monday we'll do a review session. Okay, so let's talk about our blood models. I know we've already talked about them, but you're going to be retested on them. So let's go over them one more time and make sure you know what is expected for the test. If you guys have questions at any point, please ask. I know I talk most of the time, but if you have questions, please put them in the chat, or you are welcome to interrupt me. And then that way we can make sure you guys get all this. So fibrin is the threads. Good. Each of these strands would be fibrin. And then also, if I choose a color and you can't see it, I always try to pick the best color. I don't know. There's not a great color that works all the time. Just let me know. These are our thrombocytes, or our platelets, are all of those cells in the middle. Good. And together we have a blood clot or a thrombosis. Okay. Now remember, we have our white blood cells. You need to know them as both the big models and then these little models. So both of them. So let's do the little models first. You have your neutrophil here. This guy is your neutrophil. This is your lymphocyte. This is your eosinophil. Remember, it kind of looks like the letter E. Over here is a basophil. And this is a monocyte. I always think that a monocyte kind of looks like a bean. It's my opinion. It looks like a little bean. Neutrophil always has the little three. It's three little balls. You see that with a little line in between. Eosinophil always looks like a sideways E. You can picture it like if this is an E, this looks like eosinophil. Does that make sense? Lymphocyte never has a lot of extracellular. It's always very like small and ball-like. And then the basophil, honestly, the basophil, you have to just memorize how it looks. I never came up with a way to remember. I just looked at it enough times that it finally made sense. All right, any guesses of which one you think this is? Which one do you think that one is? Good. Yep, eosinophil. Pretty easy because it looks like the one next to it, but I just thought we'd make sure that you guys got it, okay? So those are these little models, and you need to know what the little models look like as well as the big models. So I'm going to go back to the big models because at the end we'll talk about functions and all that, but that doesn't really matter which model we talk about that on. Okay. All right, so for right here, we have our, this is our monocyte. This is our eosinophil, eosinophil. You can see again, it looks like an E. Monocyte, again, it kind of looks like a bean shape. This time it's a little less bean and it's a little longer, but looks like a bean shape. Okay. Let me think. Another way that you could tell monocytes and basophils apart. Does everybody see these little, all of the ball-like structures? Those are our granules. So remember that we have our granulocyte. And then this monocyte would be a granulocyte. It doesn't have as many granules. So does everybody see how there's very little granules here versus on the eosinophil, there's a lot of them? That's because this is a granulocyte and an agranulocyte, not as many granules, a lot more granules. So when you're looking at a monocyte versus a basophil, that's one of the ways that could help you. But honestly, it's really not, it's not like a foolproof way to know. So I would just look at them enough until you get them, because it's really not. The monocyte and the basophil are the most confusing. And the lymphocyte sometimes can be confusing. So this is the lymphocyte here. This would be another one that's agranular. You guys see how there's not many granules on the, oh, I spelled it wrong. We're good, that says agranular. I know it says agranulate, but we'll just leave it. This does not have as many granules. This is our neutrophil. Does everybody see how it has lots of those little granules all in it? That's granular, it's a granulocyte. This is our basophil, and the basophil would also be granular and have a lot of those granules in it. Good? So basophil, granular. It is kind of helpful. I feel like that's kind of helpful. It's just, it's not the only thing you can look at, but it is helpful to look at granular, agranular. Okay, so let's look at our other little guys here. We'll do a little quiz. So what do we think number 1 is? Any guesses on what number 1 is? Let's do number 1, number 2, and number 3. And you could just put the letter it starts with. That's fine. We'll all know what you're talking about. You don't need to write out neutrophil or whatever. So what is 1? So you guys can do it like this. So 1, 1N would be an example like that. By the way, 1 is not a neutrophil, just so we're clear. this guy is a neutrophil. So I just gave you the answer that none of those are neutrophils. So what is 1, 2, and 3? And you can do it like that too. You can do comma, comma, comma. I'm kind of just curious what you guys are thinking. Good. All right. So everybody has them down. So 1 is our lymphocyte. 2 is our monocyte, kind of looks like a bean. 3 is our basophil. Hopefully these are ones you guys already studied when it came to the last exam. And this is just a review session and you guys already all really know these super well. Okay, so what's the other things that you're going to be tested on besides just identifying them? We're going to do the same things we did last time. So we want you to know functions. This time you're really going to need to know functions, right? Because we definitely just talked about that. So remember, never let monkeys eat bananas also goes with the mnemonic BAMP. If you can just remember that and write it on your paper on the exam, it should be pretty easy for you to get the function. Remember that this would be for neutrophils phagocytizing bacteria. A is for antigen antibody complex. M is for becomes a macrophage, monocyte becomes a macrophage. P is for phagocytizes parasites. H is for histamine and heparin. And then you would want to know whether they are agranular or granular. That would be another question, which you guys know. Agranular is site, granular is fill. And then you would also need to know most common to least common for your test. Okay, so those are the different things that you would want to know for the test. Identify them, their function, agranular or granular, most common to least common. All right, any questions there? Is that pretty clear to everybody? I know you've already covered this stuff before, so hopefully that was just a quick review and you're good on that. Okay, so then on the exam, we're also going to have this standing kidney model. It is already labeled right here for you. So you see that we have the inferior vena cava descending aorta that branches into the iliac artery and iliac vein. We have your kidneys with their renal artery and renal vein. It's very, very simple. You don't have a lot you need to know on it. It's just basically for you to look at the arteries. Inferior vena cava descending aorta, iliac artery, iliac vein. That's kind of what we're concerned about. Good. So take a look at that. Like I said, it's already labeled for you. This is like a 1-minute video of him going over it. All right, let's look at, is everybody good with going over the thorax? Even though I haven't done respiratory, I feel like we can probably go over the model. That works, right? It's okay to go over the model before you guys have really done the lecture a lot. Okay, so when we're looking at the larynx, this is like your throat. So this is looking at it from the front, and then we look at it from the side. I like the side better. I think it makes more sense for labeling the model. So this is your thyroid cartilage, okay? This is your cricoid cartilage, that little piece down there. And then these are the tracheal cartilages. And then we have our hyoid bone and our hyoid bone and our epiglottis. So the hyoid bone has the superior horn of the hyoid bone and the inferior horn of the hyoid bone. The thyroid has the superior, I always get these, I need to look at that part, and then epiglottis up here. Okay, so superior horn of the hyoid bone, inferior horn of the hyoid bone, and then we have our thyroid cartilage, cricoid, and our epiglottis. This is the greater and lesser? No, I think it's greater and lesser of the thyroid. So this is the greater horn of the thyroid cartilage. I'll change it to white because I feel like that's hard to see. Let me see. That's better. Okay, that's up here. And then right here, I'll draw like an arrow. This little part here is our lesser horn of the thyroid cartilage. Okay, and then I'm gonna use a little blue. Cricoid is this structure here. Oh, I'm supposed to change the color for me. Okay, this is the cricoid here. That makes sense. So lesser horn, greater horn, and then the cricoid. Greater horn is referring to like this part here. Okay, and then we're going to turn it and rotate it and look at the back. Let's look at the back here. Here we go. So these are our arytenoids here. Arytenoid. On the top, we have our corniculate. Oh, let me change the color. This guy. Corniculate, they're like these little like top portions. This is again our epiglottis. And this would be cricoid. The back of the cricoid cartilage would be right there. Okay. Good, and then let's go to, I'm gonna show you the last part here. We'll look at the glottis. Okay. Right here is our glottis. So the opening that allows you to make sound when you speak is this little opening here. It's like a little slit, and that is our glottis. So this is an epiglottis, like above the glottis, and that's the glottis there. Okay. Any questions? Okay, so let's go to the next model. So this is your thorax model. The thorax model is basically, if we look at it from the very outside of the model, it has our lungs and our heart. I don't really know exactly. I don't think this will let me rotate this. So this has our lungs on either side and then our heart in the middle. So what we do is we kind of take a look at the model like this. It would be without the lung pieces and just the heart sitting in the middle. And then we also will look at it without the heart. So let's start here. So this is the lobes of the lung. So remember that when you guys go over it, you're going to see that in the lung, we have 3 lobes on the right side, and then we have 2 lobes on the left. So you can kind of see that here. It's not, this picture is a little hard to see, but it's trying to show you how on the left, there's 1 and then 2, 1, 2 lobes, and then on the right, 1, 2, 3 lobes. So 3 lobes on the right, 2 lobes on the left. And then let's look at the different airways we have here. Okay, so coming down into the lungs, we have our trachea up at the top, right? So this guy is our trachea here. Trachea, it's the blue. It splits into our bronchi. So do you see how right here, there's 1 on each side? So 1 on each side, this is our, we're gonna draw 1 and 1. That represents our primary bronchi. Primary bronchi, 1 on each side. splits off the trachea. This is something that you'll be tested on for sure. Then the next thing we have is the secondary bronchi. Secondary bronchi, we have 3 on the right and 2 on the left. This becomes the lobes that I was just talking about. So here, let me do a different color. Let's do yellow. So yellow right here. This is a secondary in yellow. See how there's 3? So those would be secondary. And then over here as well, there's 2. So the yellow are our secondary. So I'm going to just kind of highlight them in yellow. Tertiary branch off from the secondary. Let's do them in green. Tertiary bronchi there are many branching off from the secondary. So if we highlight those, they're right here. So all of these guys are all tertiary bronchi. And on Monday, when we talk about the lungs, we'll talk about kind of more anatomy of the tertiary bronchi. So all of these guys would be tertiary bronchi in your lungs. That makes sense? Primary, secondary, tertiary. Other structures we have is this one right here. That is your esophagus. Esophagus. You also have your diaphragm right here. This muscle here is your diaphragm. And then we're going to talk about the blood vessels right now, but we need to put our heart in to make sure we know which ones are which, okay? So diaphragm and esophagus, and then we talked about primary, secondary, and tertiary bronchi. And I have just a few minutes, and I'll try to finish up the heart in just the next few minutes and let you guys go. I do have tutoring until noon today, okay? So if you have any questions, please don't rush out. Like I said, I'm here. Just to make sure you see it, this right here is our, that larynx again. So these would be our arytenoids once again. These are our arytenoids. You do kind of need to know this again on this model. So these are the arytenoids, and then I'll show you guys when we turn it to the side, the other structures. So just see, arytenoids are right there. Okay, looking at the front, this would be the thyroid gland and thyroid cartilage. Thyroid gland here. This is not the trachea, this thing is just staying behind. This is the hyoid bone. This down here is the cricoid cartilage. These would be tracheal rings, right? Cartilage rings. And then tracheal cartilage rings. And then this is the thyroid gland. The like yellowish structure is the thyroid gland. I don't know exactly which color. We'll just do black, okay? Thyroid gland. And then let's go, I wanna go to the heart and show you guys that before you guys go. Okay, so looking at our heart, remember that this is kind of a really good way to see your heart and its chambers is on this model right here. I like this one because we can kind of see everything at once. So let's label that really quick. So this is our right atria flowing down into our right ventricle. Remember that it flows through what? The tricuspid or right AV valve. Yes? So I'm just going to do T/RAV. Right atria through the tricuspid or right AV valve into the right ventricle, out of the pulmonary semilunar valve, which is this guy right here. Yeah, you see how he's pulmonary semilunar into the pulmonary trunk. Okay, this up here would be the superior vena cava flowing into the right atria. So our blood is kind of going right down here, up through there. Where does it go? It goes to the lungs, and then it comes back through pulmonary veins into what? Into the left atria, yes? Through the bicuspid / mitral / left AV valve, which is this guy right here, into the left ventricle, out of the aortic semilunar valve, which is right there, into what? Into the aorta. And then that's out the body. So this is a really cool picture because you can see the whole heart in kind of one place. This would be a really cool one to print and put in your like notebook for the heart. All right, I want to look at the blood vessels really quick before we go, because that's one of the main things you need to know on this model. Okay, so when we look at your heart and we see it sitting inside of the chest cavity, you're going to see that we can actually distinguish a lot of the different blood vessels here. So you can see your superior vena cava right here. Now let's go into white. SVC, this would be your superior vena cava. Down here, inferior vena cava, right? Getting into that right atria, right? Right atria down to the right ventricle and out through the pulmonary trunk. Remember, what does the pulmonary trunk become? Pulmonary arteries, right? Because arteries always go away. So these blue blood vessels are pulmonary arteries. So for your test, those blue blood vessels are pulmonary arteries, right? The ones in the lungs. And then what happens? The lungs give the blood oxygen and it comes back into the left ventricle through pulmonary veins. So the red blood vessels are pulmonary veins. So if we're pointing to just the red blood vessel, know that it would be a pulmonary vein, or just the blue blood vessel, a pulmonary artery. And remember, we go down into that left ventricle and we pump out through the aorta. And you would need to know, once again, the branches off of the aorta. Remember that the first branch is your brachiocephalic trunk or your brachiocephalic artery. The next one here, this guy, the red, is the left common carotid, and then the left subclavian, right? And the brachiocephalic trunk branches into the right subclavian and right common carotid. I'm saying this really quickly because I feel like we've already gone over that several times. The part that I would say is kind of confusing and new on this model is the red versus the blue blood vessels, and that those are pulmonary arteries and pulmonary veins, okay? So that's the part that you definitely want to be prepared to test on for that. All right, that should be everything on this model. I'm gonna let you guys go. I know it's a few minutes past 11. Thank you so much for coming. Remember, I am here until noon if you guys have any questions or you need help on any of your homework. If not, I will see you on Monday. Thank you, guys. All right, does anyone have any questions for me? Bye, thank you. Yeah, actually, you're wondering if I have any tips for arterial and venous blood tracing. So what I did when I was studying it is I actually made a little like drawing. I'll just draw it here. So like, let's say you're studying the venous blood return of the leg. I know that this looks nothing like a foot right now, but it doesn't really need to. I actually drew like a leg. I drew like a little knee, and then I drew it going back up to the abdomen. And I would like draw like the Palmer Digital. By the way, I don't remember all of them, but I know it was like Palmer Digital and then maybe like Saphenous or whatever. And then there's a posterior tibial, a popliteal, and then it goes up. Does that make sense? So what I would do is I would actually draw them on the leg and then I would label them. That's what helped me with learning it, because then it like makes you feel like you understand like what all of them are. Does that make sense? So have you, yeah, if you try with the leg, see if that helps. I drew like a whole, oh my gosh, this looks nothing like a person. Okay. I used to draw the hand, the arm. I would draw it going up to the shoulder, and then I would draw the abdomen, and then I would draw the leg, and I would kind of draw, I honestly drew it this way because like it doesn't need to look right. And I would draw it going up here so that I could practice like the femoral, iliac to femoral, right? And then the abdominal aorta and the superior vena cava. So I kind of did a lot of like drawing of it because that's definitely how I learn. Popliteal, posterior tibial. I remember where some of them are even now because of the drawings I did. I'll just be honest, I don't remember all of it. It's not really something you're going to use a whole lot in nursing school, but sometimes on patients' charts, they will show like a person had like a vein removed from the saphenous vein. And because of this, I did kind of remember it. So I would just recommend drawing them out and then using that to study, if that makes sense, if that helps. So on the arterial, I used to do the same thing. I draw like here, and then I draw the ones that go to the fingers. You could also do them side by side. So you could do like venous in blue or something, and then you could do arterial in red. And then that way you can practice them side by side. No problem. Any other questions? You're welcome to hang out as well. I'm going to be here until noon. So if you guys think of anything, I'm here.